Great, thank you. All right, good morning, everyone. If we haven't met yet, my name is Kellen, and today I'm stoked to talk with you all about inpatient recognition and management of pulmonary hypertension. My goal for this morning is to talk through some helpful things to think about and look for when you're taking care of patients with these chronic diseases in the hospital. And my goal today is not to spend a lot of time on equations and right heart cath data, and not to talk through a lot of mechanisms of action. I promise I won't show you any right heart cath pressure tracings either. I am making the assumption, though, that you all are relatively familiar with pulmonary hypertension. But if I do need to take a step back and explain things more clearly, please let me know. Let me see if I can advance my slide. There we go. To start things off, I have no financial disclosures at this time. In regards to many of these slides and this topic in general, I received some amazing help from Sam Rayner in creating a lot of these slides. He also patiently answered all my questions on this topic, so a big thanks to him. And finally, I'm just stating the obvious that although I find pulmonary hypertension super interesting, I am not an expert and I'm far from it, but I'm excited to share with you all today what I do know. In regards to the take-home points that I have for this talk, first, I'm hoping you all recognize the clues of pulmonary hypertension when you see them, and you don't just wait for the echo report to say RVSP high. Second, when you are taking care of a decompensated patient, I want you to be looking for the trigger for that decompensation and not just diurese and forget. And third, the most important thing is when you admit a patient with pulmonary arterial hypertension, it's important to continue these home medications. If you do plan on stopping them, to run that by your fellow pulmonologist. So just a general outline for this chat. First, we will start talking about defining pulmonary hypertension. Then we'll talk about ways to recognize it. Then we'll talk on the acute care management. And finally, we'll spend a little bit of time talking about IC level management with some super cool physiology. Poof, I know, math, it's gonna be okay. To start things off, I'm just gonna show you guys how I conceptualize pulmonary hypertension. And that's with Ohm's law from physics, where voltage equals current times resistance. And to the right on that picture there, you can see how we can apply this equation to a very oversimplified pulmonary vasculature system, where on the left we have our right ventricle pushing blood into the pulmonary capillaries, and it's pushing against a certain resistance to get that blood across the pulmonary capillaries, and that's the pulmonary vascular resistance. Normally, that's measured with Woods units, and a normal pulmonary vascular resistance, or PVR, is under 3 Woods units. And on the right side of the diagram, we have our post-capillary component, where we're really just focused on the left ventricle and left atrium. For hemodynamics, instead of voltage, there we go, we have the difference in pressure between the right heart and the left heart. And instead of current, we have cardiac output. And instead of resistance, we have that pulmonary vascular resistance, or PVR. I can rearrange this equation to show that the average pressure in our pulmonary artery is dependent on only a few things, really. The first one being our cardiac output. The second, how hard it is for blood to travel across the pulmonary vasculature. And third, the pressure in the left atrium. So when we define pulmonary hypertension as an average pulmonary artery pressure of more than 20 millimeters of mercury at rest, or a pulmonary vascular resistance of more than 3 Woods units, we already know what the potential causes could be just from this diagram. This pressure cutoff, by the way, of 20 millimeters of mercury is the result of the 6th World Symposium on Pulmonary Hypertension recently held in France, and was picked because 20 is 2 standard deviations above the average human pulmonary artery pressure of 15. Initially, the pressure cutoff was arbitrarily picked at 25, which I think we're all familiar with from medical school. And that was actually picked in the setting of an orexigen epidemic in Germany, with a resulting surge in pulmonary hypertension that people were struggling to diagnose. So since then, we've had a bit more refined definition in the pressure cutoff. In fact, there's growing evidence today that in some pulmonary vascular diseases, like pulmonary arterial hypertension, associated specifically with systemic sclerosis, or in chronic thromboembolic pulmonary hypertension, and in chronic lung disease patients, we know that patients with these pulmonary artery pressures between 21 and 24 so they would have been missed by the original definition. These patients are actually at a higher risk for death than their lower pressure counterparts. And this change in definition allowed these patients to start on targeted therapy earlier and be included in future treatment trials that they were originally excluded from. So when we're wondering why our pulmonary artery pressures are elevated, we can see that this is because either a precapillary lesion, such as constriction, destruction of the pulmonary arteries causing high pulmonary vascular resistance, or this could be from a post-capillary lesion, such as back pressure from a poorly functioning left ventricle. For example, if we have elevated pulmonary artery pressures with a PVR of less than 3 Woods units, which would be normal, we know that the extra pressure on the pulmonary artery is probably being driven by the left heart failure. Or if we have an elevated pulmonary artery pressure that and our left atrial pressure is 12, which would be normal, we know that that vascular resistance must be high. Before I move on, I just want to stop there to see if I have any questions. I have trouble seeing the chat, so let me know. If not, I can charge on. Great. All right, so we can combine our lesion location with our known common etiologies for pulmonary hypertension, and we can get everyone's favorite World Health Organization groups. Group 1 refers to pulmonary arterial hypertension, where here our lesion is the pulmonary arteries themselves. They can be obliterated, constricted, clotted up, or have just abnormal, disgusting vascular structures called plexiform lesions. And typically, these patients have high pulmonary artery pressures, low left atrial pressures, and some risk factors for disease development. And these factors can include just idiopathic, heritable, where BMPR2 gene is the most commonly mutated gene, toxin-induced as a cause, HIV-associated, connective disease-associated, congenital heart disease, and cirrhosis, just to name a few. Of note, methamphetamine use has only recently been recognized as a toxin with a clear association with pulmonary arterial hypertension. And that was only recently described in 2019, so super recently. And anecdotally, this contribution to pulmonary hypertension is becoming much more significant. A lot of these, knowing how many patients have these certain disease processes are kind of hard to detect the prevalence, and large registries are used nationally to understand who has this disease burden. And it seems that this platform might be shifting from under us, although it is less well characterized right now. So ongoing research is taking place. But we know of these causes, portopulmonary, connective tissue disease, and familial associated have the worst prognosis. And while all these diseases are put into a single group, it's pretty clear that they're extremely heterogeneous, but no guidelines exist recommending different treatments of different groups, and they all get the same treatment therapy regardless of etiology. Moving on to group number 2, which is historically from the mitral valve, but the definition has expanded to include heart failure with reduced ejection fraction and preserved ejection fraction. But as you may have experienced, it's hard to rule out these contributions to an elevated pulmonary artery pressure, since this seems like everyone these days has heart failure with preserved ejection fraction. So during a right heart cath, oftentimes provocative maneuvers are used on some patients who have borderline left atrial pressures, and these include fluid boluses or exercise maneuvers. And while group 2 patients may have left atrial pressure driving that elevated pulmonary artery pressure, other patients, through a variety of mechanisms that have not yet been well explained, have a component of that precapillary disease. So they have elevated left atrial pressures and an elevated PVR. So this discovery has divided the group into 2 new subtypes, one with high pulmonary artery pressures alone, just due to the backed up blood, and other with a maladaptation of the pulmonary vasculature responding to potentially years of high pressure strain. Group 3, moving on, refers to chronic lung diseases. This is typically not a patient with mild COPD or focal bronchiectasis. This is usually moderate to severe lung disease that we can identify with lung volumes through PFTs of less than 65% of predicted or worse. This can also be a cause of a PVR of 3 to 6, or a pulmonary artery systolic pressure up to 50. But we typically don't see lung disease causing numbers much higher than this. So bear that in mind when you're looking at your right heart cath data or your echo. And interestingly, these patients in this group have the highest mortality and worst quality of life compared to all the other WHO groups, which is extremely surprising to me. However, bear in mind that these patients, when they present and are diagnosed, are typically much, much older and have way more comorbidities than the rest of the groups. Group 4 refers to the chronic thromboembolic pulmonary hypertension. These are diagnosed with DQ scans, and every patient being evaluated for pulmonary hypertension needs one. But it's estimated that around 40% of CTEPH patients never had a blood clot prior to presentation, which can make this diagnosis not so obvious. These patients are also eligible for unique medical management, as well as thrombectomy procedures, only performed at a few centers in the United States. And this group is special because it is the only curable form of pulmonary hypertension that we know of. Group 5 is the mixed bag. It's got sarcoidosis, LAM, sickle cell, all this other stuff that I will not dive into. But if you're like me, and memorizing these arbitrary numbers is challenging, this is a fun trick that you guys have probably seen before, but I learned it in my inpatient pulm rotation at the U. Essentially, if you take the mirror image of each number and put it back to back with the original, you get a picture of where the disease process is. So for 1, put it back to back, it looks like an artery, right? And for 2, back to back, it looks like a heart. For 3, it looks like some lungs. 4, it looks like a chair, maybe, not really. I always thought it looked like legs going up to some lungs. I memorized it that way, so that was pretty helpful. And 5 is our mixed bag.
Kellen, a question from the chat.
Yes.
From Connor Fling. Is there a way to measure pulmonary vascular resistance directly? Or is it derived using Ohm's law, then measuring PE pressures, wedge pressures, and calculating cardiac output?
Yeah, it's going to be derived from your right heart cath data. Pulmonary vascular resistance, that's going to be the pressure on the left side minus the pressure on the right side. And you're going to divide that by the cardiac output. All of that is going to be calculated with data from your right heart cath. Not measured directly, yep. It's helpful because that way everything is standardized to a cardiac output. But you can just measure the deltas between the two separately and get that gradient pressure, but that's harder to apply to a larger population of patients. Great. Thank you for the question. So which of these groups is most common? By far, group 2 wins. However, these numbers are hard to rely on. As I mentioned before, prevalence is extremely poorly characterized. So most of what we see is not due to pulmonary arterial hypertension. In fact, 80% of pulmonary hypertension is caused by group 2 or group 3, so bad hearts and bad lungs. When we do zoom in on our pulmonary arterial hypertension group, we see that idiopathic is the biggest contributor, so not helpful. And pulmonary vasodilators are really only going to be used in this pulmonary arterial hypertension group, and sometimes in group 4. So really 85% of the patients with pulmonary hypertension, we don't need to worry about these special PAH medications. We can also try to grade a patient's severity in pulmonary hypertension. I'll just show this briefly because I know we're not going to be doing this as we're writing our admission notes, but this is what the pulmonologist will be looking at. They look at right heart function, how fast the disease is progressing, syncope, functional class, BNP, if they have a pericardial effusion or not, and basic hemodynamic parameters, which interestingly, mean pulmonary arterial pressure is not one of them. And the goal for treating these patients is to shift them from the right side of the screen to the left side of the screen. I'm going to talk a little bit about medications. While in smaller like community practices, taking care of patients with group 1 is pretty rare, but it happens all the time at University of Washington. So although I know the chances of us prescribing these medications are small, I'm going to run through some common meds PAH patients will be on so that you can recognize them and continue their use while they're being admitted. Additionally, it's not uncommon for patients to be admitted while their meds are actively being up titrated in the outpatient setting. So recognizing side effects can be super helpful as well. For the first pathway is for pulmonary arterial hypertension treatment is the nitric oxide pathway. This involves sildenafil, tadalafil, and riociguat. We can see that these medications provide a benefit pretty quickly, but we need to watch out for some hypotension, headache, flushing, and to not use any nitrates with these medications. Endothelin receptor antagonists are the next group. These can take weeks to work and ironically cause fluid retention as a side effect. So it's common that we need to up titrate our diuretics when we're starting these medications. So if we're looking for a cause for a decompensation, this is a possibility. Prostacyclins are next, and this takes a long time to up titrate, although there are some effects in the short term. Dose up titration is limited by side effects. And finally, calcium channel blockers seem to be the less recognized pulmonary arterial hypertension medication. But for the lucky few who hemodynamically respond well to these, they can actually be used as a monotherapy, at least for a short time. So if these patients are being admitted with a home medication for a super high dose of amlodipine and they're hypotensive, please talk to a pulmonary team member before just holding this medication, as this may be essential for the patient's forward flow. For all these medications, although they have marginal impact on systemic blood pressure, they have large impacts on reducing the pressures in the pulmonary arteries and reducing the pulmonary vascular resistance, therefore allowing significantly more forward flow and improving overall blood pressure. So although you may get asked about holding a blood pressure medication when a patient is hypotensive, just remember that their forward flow is dependent on that low pulmonary vascular resistance, and stopping the med may actually drop the patient's blood pressure due to backup in the lungs. Any questions there? I can stop there. Cool.
Sorry, Kellen, I had a quick question.
Yeah, please.
I'm a little confused about, so some of these are dihydropyridine and non-dihydropyridine. I feel like I think of them like pretty differently. So how come they're both treatments? And can you go over that part a little bit?
Oh my gosh, I wish I could. I just know that these are all used clinically. I do not know why. You'd expect some to work and some to not work, but no, I cannot go into that, unfortunately. I'm sorry. Good question. I'm going to get back to you about that though, because that's interesting. Any other thoughts that I may or may not be able to answer? Cool. Well, so we talked a lot about a background in pulmonary hypertension. So let's switch gears and discuss what a patient will look like when we see them in the hospital or in the ED when we're admitting them. So in this study that was actually done in the 1980s, describes that patients with pulmonary hypertension present with dyspnea as the most common symptom, not surprisingly. Other symptoms include fatigue, presyncope, chest pain that occurs, and all this happens because of the inability to increase our cardiac output to meet demand. Additionally, progressive pulmonary artery dilation can cause hoarseness with laryngeal nerve compression. Wheezing can be caused by airway constrictions from large blood vessels, and even chest pain can be caused by coronary artery compression. Interestingly, on physical exam, the most common finding was a loud P2, with peripheral edema only being about 32%, although we think of these patients as always presenting with fluid volume overloaded status. So since P2 is going to be our most common physical exam finding, I thought we would just take a step back and talk about what this is, because I never fully understood this. So when we are auscultating someone's heart, our S2 heart sound is the sound of the aortic valve and the pulmonic valve closing. And during expiration in a healthy person, this happens at about the same time. So we just end up hearing one S2 sound. When a healthy person inspires, their diaphragm moves down, creates negative thoracic pressure, so more blood than usual is sucked into the right ventricle. And now when the right ventricle squeezes, it has so much more blood to move forward, it can't quite keep up with the left ventricle. So the closure of the pulmonic valve is slightly delayed. If you're good at hearing heart sounds, you bust out your Littman Cardiology 3, and you should be able to hear that physiologic splitting during inspiration, but you should only be able to hear it in the pulmonic window, which is in the yellow there. If you move your stethoscope over to the aortic window and you still hear that splitting sound, that is abnormal. That is a loud P2. So loud P2 has nothing to do with how it sounds compared to S1, which was something I was very confused about. Another classic physical exam finding is going to be our fixed split S2. This occurs when you can hear the A2 and P2 as two separate sounds, both during inspiration and expiration. And this is telling you that at all times during the respiratory cycle, your pulmonic valve is delayed in closing, implying that it constantly has too much work to do. Maybe it's pushing up against too much afterload like pulmonary hypertension or pulmonic valve stenosis, or maybe it's expected to push too much fluid around like atrial septal defect or volume overload, or maybe your right heart just isn't working very well, like right heart failure from acute coronary syndrome or other causes. Since patients with pulmonary hypertension are presenting with dyspnea, chances are they got an EKG down in the ED. EKG signs in pulmonary hypertension are not sensitive, but they are specific. And interestingly, they don't correlate to severity of disease. So you can sometimes see a right axis deviation, large P waves in lead 2, and you can see that S1Q3T3 pattern of right heart strain that we see with active, sometimes see in acute PE. We also can see right ventricle hypertrophy and rarely signs of right heart strain with those ST depressions. We can also see signs of pulmonary, oh yeah, go ahead.
We have some interest in the chat for you to repeat the explanation of the loud P2.
Oh my gosh, yes. Okay, great. So I'm gonna go back to that slide. Okay, so we should be able to hear the aortic valve and the pulmonic valve closing at different times when the inspiratory phase of the respiratory cycle. We should be able to hear those two, but only when we're listening in the pulmonic window. If we move our stethoscope over to the aortic window and during inspiration, we still hear that split, just hearing that P2 sound not in the pulmonic window means that that P2 noise is too loud. Does that make sense?
Yes.
Terrific. All right. All right. Moving on to chest x-rays for physical exam, or not for physical exam, but for objective data. If we look at the moguls of the heart, we can see here that the first mogul is the aortic arch, while the main pulmonary artery is the second mogul. And this structure also pokes out the back of the right side of the heart as well. So when we look at a chest x-ray of a patient with pulmonary hypertension, we can see that we have some evidence of right atrial enlargement here. We can also see some pulmonary artery enlargement and right atrial enlargement as well. And we also see some evidence of right ventricle enlargement, although I don't think that's a very sensitive examination. I found that when I'm admitting somebody also from the ED with dyspnea, chances are that the emergency department also got a CT to rule out a pulmonary embolism. And this study can actually be super helpful for us to be looking for signs of pulmonary hypertension. So when we scroll down the images, we find the bifurcation of the right pulmonary artery, and you can look at the right pulmonary artery size at this point, and we can see how it compares to the aorta. If it measures, or if the pulmonary artery measures more than 31.6 millimeters, that is 47% sensitive and 93% specific for pulmonary hypertension. If we compare it just to the size of the aorta next door, we can see that the ratio also has some diagnostic power. However, as this study was done in 1999, before the diagnosis of PH has changed, this may mean that the sensitivities are now higher than I'm reporting right now, and the specificities are now lower. But still interesting.
Ellen, question from the VA.
Yeah.
Is it true that both loud P2 and fixed splitting are associated with pulmonary hypertension?
Yes, they both are associated with it. However, there can be multiple causes for all of them. So just because you have both occurring at the same time, that is not specific for your diagnosis of pulmonary hypertension. All right. So now that we've gotten some clues that this patient has elevated pulmonary pressures, because we're great at looking at objective data, we are for sure going to order an echocardiogram. However, it's important to remember that this test only stratifies the likelihood of pulmonary hypertension, and it does not necessarily diagnose it. This will help us determine if the patient needs a right heart catheterization. Additionally, we can evaluate the function of the right ventricle, which is going to be important for prognosis. An echo can also give us clues to the etiology of PH, like if they have left heart disease or congenital heart disease, maybe they have mitral valve dysfunction, or maybe we can look at their volume status as well. So on an echo, some pretty classic findings are going to be some right ventricular size changes, pulmonary artery size, pulmonic valve size, and right atrium size. Other findings of the pulmonary hypertension are going to include right ventricle to LV ratio and maybe flattening of the septum. And of course, the thing that our eyes immediately go to are the pulmonary artery systolic pressure. And that's going to be calculated from the peak tricuspid regurgitation velocity. Putting all these data together, we can estimate the probability of pulmonary hypertension and decide if a right heart cath is even needed. So as you can see, a high enough tricuspid jet down at the bottom in the red reflects a super high pressure in the right ventricle systolic pressure. And because because that's such a high correlation with pulmonary hypertension being found on right heart cath, you do not necessarily need to have any other findings of pulmonary hypertension. For indeterminate or intermediate category patients, the decision to cath is more nuanced. And interestingly, tricuspid regurgitant velocity can increase with volume overload. And this is taken into account when we decide if we want to right heart cath or not. Excuse me. All right. If there are super strong suspicions for left heart disease based on the echo and clinical features, oftentimes we can just assign the WHO group 2 to these patients if there's no other concerning features, and we can hold off on right heart cath at this time as long as all the data is lining up for that diagnosis. Finally, it's possible to just repeat an echo, especially in these low probability patients, especially after they've been diuresed. And a lot of times that can return the pressures down to normal, and right heart cath is not necessarily needed for these patients. All right. So in general, right heart cath is needed to make a diagnosis and before starting any patients on pulmonary arterial hypertension therapy. That's pretty darn important. Although you see some patients get put on sildenafil casually when we're leading towards a pretty clear diagnosis of pulmonary arterial hypertension. Additionally, the pulmonology team will likely request the following studies, which can usually be completed in the outpatient setting, but these include CTA chest, PFTs, sleep study to really look to see if there's a group 3 contribution to this, VQ scan to make sure that this isn't a CTEPH presentation or that group 4, and autoimmune labs as well, just to see if there's any component of pulmonary arterial hypertension, even if there is a existing left heart abnormality going on. Phew. Okay, I'll stop there. Are there any questions in the chat or any clarification points I should address?
I think we're good.
Cool. So far, we've talked about pulmonary hypertension, what it is, how to recognize it, how to diagnose it, and now I can move on to some basic concepts of caring for patients with pulmonary hypertension when they're admitted to your service. The first important thing to know about pulmonary hypertension is that it is a slow and steady disease. Patients are usually not being admitted to the hospital because of a flare from this chronic disease process. Patients are getting admitted because they have an acute insult to a delicately balanced physiology. So when you're evaluating a patient, you should be looking for things that can cause a fast change: infection, anemia, arrhythmia, acute coronary syndrome, pulmonary embolism, misdiuresis, diet changes. All of these things need to be carefully evaluated. For me, this is analogous to admitting a patient with decompensated heart failure. It's not enough just to make the diagnosis. It's essential to understand what the event triggered the decompensation. In a study that looked at hospitalized patients and deaths in patients with pulmonary arterial hypertension at the Cleveland Clinic, it was found that more than half the patients with PAH deaths were caused by an insult on a delicate physiology, with sepsis being the most common cause. Pulmonary embolism is also a big one not to miss and hard to rule out. However, I think it goes without saying that like Wells criteria and your PERC calculations were not validated in these patients. So that makes these risk calculators not super helpful. Additionally, D-dimers are significantly elevated in these patients compared to normal patients. And they actually track with disease severity. So these are also less helpful. So unfortunately, you're gonna have to rely on your clinical suspicion to rule in or rule out pulmonary embolism. All right, when a patient is being admitted, the first thing we need to think about is their home medications. Sometimes these medications are rare, very expensive, and there can be significant hoops for pharmacy to jump through to deliver meds to bedside. So having a patient bring in their home meds when they're able, or reaching out to the pharmacy early is a really smart way to get ahead of this. And some of these medications, particularly the ones that run on a continuous infusion, have very short half-lives. So interrupting these medications may not be well tolerated. Additionally, stopping these medications can actually cause a pulmonary hypertension rebound, setting you up for not success. And for this reason, just continuing all pH-specific medications is going to be important. And if the patient is on IV therapy, it's important to take a look at the line to just see if there's any signs of infection, going back to our initial trigger for understanding the cause for their presentation. So assessing the IV with patients who receive this IV therapy, assessing the line is going to be important. If you do not suspect a line infection and these patients are just generally ill appearing, you don't want to get blood cultures from that line. You can just get 2 peripherals. But, if the central line is not functioning for any reason, treprostinil and epoprostenil, they can also be run peripherally when you're in a pinch. So while reaching out to Pulm for further guidance is going to be essential, having the nurse in the meantime place 2 peripheral IVs is going to be a great way to start getting this treatment in action or in motion. And just an FYI, while these medications are being run peripherally, they need a stat or ICU nurse with experience in these lines to manage them, because not priming the lines can lead to a delay in therapy for hours, whereas inappropriately flushing the lines can lead to a significant overdose. If the lines do look infected, the PH team will definitely be running the show, but they will likely need the primary team, you guys, to place orders, which can include but are not limited to that peripheral IV placement we discussed, blood cultures. In this case, pulling them off the Hickman line or the central line will be important. Skin swabbing of the exudate at that line site will be important as well. Empiric antibiotics are just going to be intravascular infection antibiotics, so vancomycin, cefepime, and catheter salvage for these patients is very rare because we really prioritize source control since these patients are so tenuous. In that setting, small fluid boluses are okay, but we transition quickly to vasopressors, but I'll get into that in a moment. And of course, even during a routine admission, talking to Pulm consult team and who's in direct communication with the patient's outpatient pulmonary hypertension doctor is a great place to start. All right. In general, on admission, these patients should be cared for like decompensated heart failure patients. They will need a BMP to look for signs of renal congestion. Electrolyte abnormalities should be checked just in anticipation of starting diuretics. Creatinine is frequently elevated in these patients, just in general, and this should not be a justification for holding diuretics. LFTs can be helpful in evaluating for hepatic congestion. And additionally, some pulmonary arterial hypertension medications like bosentan can have liver toxicities, and that's the helpful way to evaluate that as well. BNP is interesting and can be compared to previous BNPs to identify volume status. The half-life of BNP is 23 minutes, while the half-life of NT-proBNP fragment has a half-life of 60 to 120 minutes. And because of this short time frame, the time needed to reflect meaningful changes in hemodynamic status is approximately 2 hours for BNP and 12 hours for NT-proBNP. So for this reason, NT-proBNP rise may be delayed by hours following an episode of flash pulmonary edema. So keep that in mind if you're hanging your hat on a low NT-proBNP for your diagnosis. Oh, and bonus points are given for ordering a BNP at around the time of discharge when the patient's euvolemic for future reference. CBC is also needed for anemia, infection, strict eyes and nose with admission, daily weights, all that good stuff as well. And finally, patients with pulmonary arterial hypertension are often very iron deficient without being anemic. It's hypothesized that this is associated with hepcidin levels, commonly implicated in anemia of chronic disease. And since iron availability has been known or has been theorized to influence pulmonary vasoconstriction in response to hypoxia, there is a theoretical benefit to identifying this. Additionally, there is some evidence to suggest that patients feel better when you just treat their iron deficiency. Recently, they looked at 2 randomized crossover trials to look at if this iron supplementation actually improved hemodynamics in pulmonary hypertension. And they found that no benefit exists. So if you are going to treat this patient's iron deficiency, that is totally appropriate, as these studies show that that is a safe thing to do, but don't expect any benefit hemodynamically from that strategy. Our next step, shockingly, is to optimize fluid balance. I was once told that pulmonary hypertension patients are volume overloaded until proven otherwise. So PH patients just notoriously have a very challenging volume exam. Therefore, your volume assessment should not just hinge on this physical exam alone. And looking for recent rate changes to compare is going to be essential. If a patient is stable, it's just okay to throw some diuretics and see what happens. I think that we are all familiar with Lasix as a 6-hour duration, but I think it's helpful to know that when using a different diuretic, we have different durations of action as well. And this will be helpful to keep in mind when we're evaluating for the response of a certain dose when we're trying to diurese a patient while in the hospital. And a final point about Lasix bioavailability is not great, especially in the setting of variable gut edema. As we all know, switching from PO to IV is helpful. But when we're thinking about discharging these patients from the hospital with new medications, we can think about not PO Lasix as other medications have more consistent bioavailability, and there is evidence to support a decreased hospitalization with that transition. Whew. Okay.
Question
So we've talked about,
Kellen, from Natalia Filipek.
Mhm.
She has a question if TID dosing of furosemide is similar to a Lasix IV drip infusion.
Yeah, I think that, oh my gosh, those are studies with heart failure decompensation comparing, I do not know the name of the trial, comparing like continuous Lasix infusions to TID or Q8 bolus dosing. I believe they found that those were equivalent. I do not think a study like that has been done in pulmonary hypertension diuresis specifically. So I don't know. All right. So we talked about pulmonary hypertension, what it is. We talked about ways we can recognize it, how we can take care of a patient during an admission. And next, I want to spend a little time talking about why patients with pulmonary hypertension are so tenuous. And I want to introduce the mental model of right heart failure, vicious cycle, or more pessimistically named the RV death spiral. In many cases, patients with pulmonary hypertension get into trouble when there's an acute increase in the right ventricle afterload. This can kick off a whole slippery slope. So high RV afterload, maybe from an acute pulmonary embolism, for example, will cause increased right ventricle stress as it pushes against that extra resistance. This resultant buildup of pressure and volume in the right ventricle can also contribute to right ventricle dilation. If present, this dilation can also worsen tricuspid regurg, although it may not be there necessarily. And since this right ventricle is in a low pressure, high volume machine, this extra stress and volume leads to a decrease in right ventricle output, since it just can't handle that extra strain. As our cardiopulmonary vasculature is in series, this results in less preload to the left ventricle. And to make things worse, as the right ventricle gets more and more dilated, it can start pushing against the left ventricle. As pressure gets high enough, it can even press the intraventricular septum into the left ventricle, making it actually shrink in size. And we can see this on ultrasound, and it's referred to as the D sign. Shri actually gave an excellent academic half-day talk about this, which you guys can find and watch on your own. He does a great job explaining it, so I would encourage you to check that if you're not familiar with this physiology. As you can imagine, this left ventricle compression also decreases left ventricle preload. And less preload means less forward flow. So this leads to a decrease in left ventricle outflow, which leads to systemic hypotension, and finally, cardiogenic shock. But unfortunately, our vicious cycle does not end there. Since our coronary artery perfusion is dependent on our systemic blood flow, we now have a compromised pressure gradient supplying blood flow to the coronary arteries. As you can imagine, the right ventricle stress and dilation that helps kick off this may lead to some tachycardia. This tachycardia may be reflex tachycardia from our drop in blood pressure, or maybe the RV dilation has triggered a tachyarrhythmia. But this means that the LV has less filling time so that there is less preload going on. And since coronary arteries perfuse the heart during diastole instead of systole, this tachycardia means that we're spending less time perfusing the heart as well. Our right ventricle, regardless, has an increased oxygen demand with less blood supply, setting us up for right ventricle ischemia. And also the high pressure dilation of the right ventricle, back on the left side, can squeeze the right coronary artery, further worsening this perfusion gradient and worsening blood supply. This will feed back and further worsen our right ventricle output in general. So when patients with pulmonary hypertension present in this decompensated state, this is the pathway we're working against. Hypoxia, ARDS, acute pulmonary embolism, stimulants, or rebound from stopping PAH drugs can all kick this off and send us down this bad path. Additionally, a hypervolemic state can cause right ventricle strain. Acute coronary syndrome can cause RV ischemia, and sepsis or an acute bleed can trigger this spiral as well. All right. So it's important to keep in mind that this vicious cycle exists when we're trying to treat our patients, because a lot of what we do can actually exacerbate this vicious cycle. For example, giving IV fluids can do bad things, although sometimes they are appropriate. So being cautious here is a good idea. When treating a bleed, platelets and FFP, while important for treating these coagulopathies, can actually worsen pulmonary vascular resistance and worsen that afterload. So they must be given with caution. And while using vasopressors can help improve systemic blood pressure, it might trigger a tachyarrhythmia, which can then overall worsen our hemodynamics. And it's commonly remarked that intubating a patient with pulmonary hypertension is very scary, and we can actually see why from this vicious cycle here. Many medications used for anesthesia induction suppress cardiac contractility and can drop our systemic blood pressures. This drop in systemic blood pressure can significantly worsen our left ventricle septal and causing a left ventricle septal shift as well. And again, causing our left ventricle to get squeezed even more and have less output. So once we manage to intubate this patient, we may have too much positive pressure, too much volume or pushing into the lungs. And this again can compress our pulmonary capillaries, thus worsening our right ventricle afterload. Transient hypoxia and hypercapnia can also increase pulmonary vascular resistance. So putting all of these things together sets us up for a very risky procedure that we should all be aware of. Well, yes.
Sorry, question from the chat from Kim Matsumoto. Does this happen with chronic pulmonary hypertension, or is it more seen in acute causes?
So when we have chronic pulmonary hypertension, we are going to be balanced on a knife edge here. So we are going to be compensating for that. Our bodies are going to be fighting against this vicious cycle, but just barely. And so when we have an acute insult like a PE causing acute pulmonary hypertension, these patients with pulmonary hypertension to begin with chronically are just so susceptible to be pushed over into this type of physiology. However, this is not just restricted to patients with chronic pulmonary hypertension. The exact same physiology can take place when we do have acute increases in pulmonary hypertension. However, those patients who don't have this compromised ability to compensate, it's less of a slippery slope, although all the same physiology is still at play. Cool. So while detailed ICU management in pulmonary hypertension is definitely beyond the scope of this talk, I just want to use this framework to show how our interventions can bail our patients out of this cycle. Pulmonary vasodilators can improve pulmonary vascular resistance. Diuretics can reduce RV overload and dilation. And thoughtful use of vasopressors can limit tachyarrhythmias, and aggressively treating arrhythmias can improve ischemia and output. Oxygen therapies can improve RV and systemic hypoxia, and inotropes can actually augment our cardiac output. All right, just to summarize a few of those concepts there, for general management of pulmonary hypertension patients. In hypotension, our goal is to reduce our pulmonary vascular resistance, augment our cardiac output, and improve systemic hypotension while avoiding tachyarrhythmias. There are no randomized trials I'm aware of pitting vasopressor against each other, likely because each patient's physiology is so unique. Dobutamine is often reached for in these situations. In animals, we know that dobutamine can actually decrease pulmonary vascular resistance, increase cardiac output, but we do have that weighted downside of triggering tachyarrhythmias. Rarely, dobutamine can cause slight hypotension from activation of peripheral B2 receptors, but it's something to be aware of and is also thought of when we're initiating dobutamine in addition to something like norepi. In regards to intubation, avoid when possible and use low tidal volumes. And unlike ARDS management, we do not use a PEEP bladder in these patients. We want to keep PEEP or all pressures as low as possible. A common ventilator strategy also in ARDS is this permissive hypercapnia, where having a pH systemically down to like 7.2 that's totally fine, but do not apply that rule to patients with pulmonary hypertension, as this permissive hypercapnia can also cause pulmonary vasculature resistance to be significantly increased. In regards to arrhythmias, when a patient does go into atrial fibrillation or some other tachyarrhythmia, this is going to be very important to have an urgent consult to cardiology for a cardioversion. And since these patients have such unique physiology and they can react to vasopressors or medications in very different ways, placement of a right heart cath during the ICU or floating a swan can actually help to evaluate changes in pressure throughout the hospital course for these patients and figure out exactly if we are successfully treating pulmonary vascular resistance and cardiac output with our interventions and gauge our success there. So to circle back, today we talked about pulmonary hypertension, how we can recognize it, how we can manage it on the acute care service. And we also talked about the vicious cycle that these patients are primed for and ways we can avoid it. So I've got some references here for fun, but I'm happy to take any other questions if they exist.
Awesome, Kellen, thanks so much. I'm going to send the interns off to intern core curriculum. And then we do have one other question in the chat from Hasib. Are there any specific vasopressors that work better or worse in supporting these patients?
I was looking into that, and not that I found in clinical trials, they just haven't been looked at. I know there's that theoretical advantage with dobutamine, but I can't answer you with like clinical data. It's all provider dependent at that point. I'm happy to email you with the research that I've looked into so far, though.
I had a question too, Kellen. Are you aware when I was thinking about what situations in which I would have stopped someone's pulmonary hypertension med would maybe because I was worried about renal clearance and any of those medications? Do you know, or should we be worried about that if a patient comes in overloaded and with congestive nephropathy and an elevated creatinine? That's not a reason, still not a reason to stop those medications.
That is correct. That is not a reason to stop those medications. However, pharmacy will definitely flag you. But from all my reading about this, that has not been an issue I've come up with. That's a great question though, and I'm also going to confirm that. Thank you.
Awesome. Well, we're getting lots of love for you in the chat, Kellen. So great presentation. Always a hot topic because it's pretty scary to manage. Thank you all for being here. So interns should be off. Hasib says, not sure if I feel more or less scared, which I totally agree with. Seniors, you have the rest of the morning off, so enjoy it. Good to see everyone.